talk on as far as the non-invasive ventilation is concerned. But there has been a lot of roller coaster in terms of the evidence for HFNC. Is it good for RDS? It was not found to be very effective. Then was it found effective? I think the acceptance of HFNC has been more for the comfort of use rather than evidence-based. That's my personal opinion. Yes, and whether it works as well as a CPAP or is it not as good as CPAP? What's the current evidence? How do we use HFNC? I think that was the whole gist of the talk which Dr. Aparna is going to give. Dr. Aparna, happy to introduce Dr. Aparna. She has done both her MD and DM from two prestigious institutes in the country. She has done her MD from PJ Chandigarh, my parent institute where I did my DM, and she has done a DM neonatology from All India Institute of Medical Science in 2013, if I'm right, and currently working at Ankura Hospital at Hyderabad. And I think she's an expert, I would say, on non-invasive ventilation and an excellent orator. So, Dr. Aparna, over to you.
Okay, thank you very much, Dr. Pradeep, Dr. Abhishek. I hope I'm audible.
Yeah, you are.
So at the outset, my sincere gratitude to the organizers of Neoweb lecture series. This has been a wonderful portal for us to keep in touch with academics, and I think we have all benefited a lot from the lectures that they have been regularly organizing. So hearty congratulations and heartfelt gratitude to the platform. So without much delay, I thank Dr. Pradeep for his kind introduction, and we will proceed with today's talk on HFNC, Heated Humidified High Flow Nasal Cannula Therapy. I hope that you all are able to screen here.
Yes.
If not, please do let me know. Thank you.
Yeah, we are seeing your screen. Yeah.
Okay. So a brief overview of today's talk would be, we would start with a discussion on why a need for HFNC in the first place, and we will be discussing the mechanisms of action of HFNC. We shall be briefly discussing the different available devices in our country and the interfaces available. We will touch upon evidence comparing high flow versus CPAP particularly in context of primary respiratory distress syndrome and in post-extubation support. And we will briefly also discuss the role of HFNC in treatment of bronchiolitis in children. As neonatologists, some of us may have to take care of our preemies who get readmitted with viral bronchiolitis and similar infections. And we shall be concluding with recommendations and current evidence-based clinical guidelines available for the use of HFNC in neonates. So we are all aware that continuous positive airway pressure or CPAP remains the gold standard when it comes to the optimal respiratory support in preterm very low birth weight neonates. The structure of CPAP consists of a blended source of air and oxygen, which is heated and humidified with a servo control humidifier, and is delivered to the neonate by an which can be a binasal prongs, short binasal prongs, or nasal mask, which are more commonly used these days. And we have an expiratory limb, which is typically immersed in underwater seal, which kind of guides us to the delivered pressure or delivered PEEP. Now, although CPAP is a wonderful and much preferred and commonly used mode of respiratory support in preterm neonates especially, we are all aware that CPAP does not come without problems. Some of the common problems are pulmonary air leaks, pneumothorax, and interstitial emphysema. There may be gastric distension, or what we know as CPAP belly syndrome, which is less often described or encountered these days. However, nasal injury remains a significant issue, especially with extremely preterm neonates who require prolonged duration of CPAP. And there could be a chance of over-distension of the chest, leading to decreased venous return and decreased cardiac output. Nursing care remains quite intense with CPAP, and there is a steep learning curve. So with all these issues associated with CPAP, there has been a search for an alternative which could still have the same efficacy in terms of treatment of respiratory distress, but could probably try and do away with some of the issues that we encounter with CPAP. And probably this was the search that led on to the discovery of high flow nasal cannula. So HHHFNC, humidified heated high flow nasal cannula, as we all know it, is not truly a new mode of support because it has been in vogue almost for a decade and a half now. Typically, HFNC comprises the delivery of blended gas comprising a mix of air and oxygen delivered to the neonate using smaller binasal prongs, which are typically smaller than CPAP, and we will be looking into this a little bit more closely in the coming slides. And essentially, this serves as a simpler interface, which is used to deliver gas flows, typically, as we say, high flow. These are typically gas flows more than 1 liter per minute, and these have to be heated, humidified, and blended. So what we call often as humidification of gas is an essential and indispensable component of HFNC. So for the rest of the presentation, for want of, for simplicity, I shall just refer to it as HFNC and omitting the other two H's. So the typical stand of HFNC in neonatology is it takes a middle part, CPAP, which is on our right, which is the standard of care in very low birth weight neonates and is preferred mode of post-extubation support or primary treatment distress, and is associated with the reduction in extubation failure, prevention of apneas, increasing the functional residual capacity, but may be associated with a higher risk of nasal trauma to the tune of up to 40-50% or even higher in the more predisposed neonates. And on the other side, to the non-heated humidified, which is typically low flow, you deliver oxygen at flow rates less than 1 liter per minute. Easy to give, simple to administer. Low flow nasal cannula use does not improve respiratory mechanics, and in preterm neonates actually hazardous, increasing the risk of free radical diseases like retinopathy of prematurity and bronchopulmonary dysplasia. So we have HFNC as a very alternative to our nurses and to families, providing to humidify neonates, and typically at rates which are higher than the non-humidified low flow nasal cannula. Are you clear? All good? Okay. So my audio, please do let me know if not. So definitely use of HFNC. Okay, thank you. Use of HFNC has certainly been on the rise, and as evidenced in survey was published in the year 2000, the use of HFNC across Australian and New Zealand units increased to nearly 24% from around 8% in 2009. So in a matter of less than 5 years, there was almost 2.5 times increase in the use uptake of HFNC. And in a survey conducted across the United States and the UK, it was reported that as much as 70% of the NICUs were using HFNC. And typical gas flows range from 2 to 8 liters per minute. So this figure, which has often been quoted and used in a lot of reviews on HFNC, shows the utilization rate of various modes of respiratory support. We can see CPAP indicated by the yellow line here, HFNC indicated by the red line, introduced somewhere around 2002. And we can find that already by the year 2004, the number of HFNC days across NICUs had exceeded the number of CPAP days. And we can see that the violet line here represents the number of ventilator days. And somewhere around 2010, the HFNC days had also gone past the ventilator days. Interestingly, in most of units like ours, we would find the number of ventilator days to be much lesser than the number of non-invasive ventilator days, and hence CPAP and HFNC both continue to be important modes of respiratory support across units. So we understood that HFNC is now an emerging and an evolving mode of respiratory support ever since it was introduced in 2002. And may I now request Dr. Abhishek to display the first poll question for all of us. And we shall begin our discussion on mechanisms of action on HFNC following this poll. Can we have the first poll, please, Dr. Abhishek? Dr. Abhishek, are you there?
Come on.
Can we have the first poll?
Sure, ma'am. I request all participants to mute their phones. Mute the audio, please.
So before we proceed to the discussion on the mechanisms of action of HFNC, we just thought we will involve all of you in having a small poll. So let's first kind of understand the existing sort of concept that all of us have on the various mechanisms of HFNC. I hope you are able to see the poll on your screens now. So I shall read out the question. Which of the following is not a mechanism of action of HFNC? And you can see the 4 options A, B, C, D. So I request all the participants to kindly take the poll. You can choose any of the 4 options and submit it. So let's take 20 seconds. So you have 20 seconds. Kindly choose which of the following you think is not a mechanism of action of HFNC. Flushing of the nasopharyngeal dead space, inconsistent generation of pharyngeal PEEP, reduced apneas by stimulating the respiratory center, and reduced energy spent in metabolic conditioning of inspired gas. So I think we have 5 more seconds to go. And yes, we can wrap up the poll. So can we have the responses? Do we have the responses available now?
Okay. Just a minute. Some people are trying to still answer. 5 seconds more.
Okay, sure. Okay. Yes.
Of them have answered. No, ma'am.
Okay.
40% have answered as C.
Yes. So most of you have opted for answer C, 43%, and 31% of the participants have still not answered any of the, taken any of the 4 options. And B, 13.7%, and it is followed equally by option A and D. So I agree with all of you that option C is not one of the mechanisms of HFNC. So with that, I'll kind of go back to the presentation. Okay, so I hope once again that you are able to see my slides.
Yeah.
Yes, okay. Yeah. Right. So, okay. So as you all rightly said, stimulation of the respiratory center is not one of the mechanisms of action of HFNC. All the other 3 options are well-documented mechanisms of action. So let us take them up one by one. The first and one of the most important mechanisms is the flushing of the nasopharyngeal dead space. Now, in order to understand this mechanism, let us just revisit the respiratory physiology and anatomy, and where we all know that the inhaled gases pass through the initial, the nasopharynx, the trachea, the proximal part of the bronchus, the primary bronchi, and the initial few generations of the bronchioles, which are essentially contributing to anatomical dead space because of the fact that they are just conducting airways and they do not really participate in gas exchange. Now, this volume typically is contributed by the upper airways, nose, pharynx, the trachea, and the first few generations of the bronchi. So imagine when a person has to inhale gas, the inhaled gas has to actually traverse this entire distance of the anatomical dead space before it reaches the terminal bronchioles and the alveoli where actual gas exchange takes place. So it is found that in normal respiration, almost 1/3 of the inhaled gas is comprised of the exhaled gas, which is already present in the anatomical dead space, which is relatively rich in carbon dioxide and is oxygen deplete. So if we assume that the inhaled gas, which is inspired by us, should contain 21% oxygen and negligible quantities of carbon dioxide, it is actually found that because of the entrainment of 1/3 of the exhaled gases, which is already present in the anatomical dead space, the typical concentration of oxygen in the inhaled gases which reach the alveoli only has around 15 to 16% oxygen and may contain maybe 5 to 6% of carbon dioxide. So this may further compromise the gas exchange in a neonate who already has parenchymal lung disease. So the flushing of this part of the nasopharyngeal dead space with the fresh gas, which is already kind of oxygen replete and CO2 deplete, actually helps in enabling better carbon dioxide washout and improving oxygenation because it entrails the fresh air containing oxygen. And it also has some benefit in the prevention of obstructive episodes of apnea. It was found that oxygenation was particularly improved with the use of HFNC even in the presence of high leak, because obviously the presence of leak would enabling better flushing of the nasopharyngeal dead space. So I would kind of take the help of this analogy, which was used by Dr. Mangala Bharati in his online teaching on NEOS, where he compared HFNC to a well where you would find water which is present at a much higher level as compared to a well here on the left side where the water is present at much more depth. So in which of the two wells would it be easier for us to draw water out? The answer is obvious. It would be easier when the water is already available at a lesser height from us. So similar to this, HFNC entrains the fresh flow of oxygen replete and carbon dioxide deplete gases, which are more readily available to the neonate, closer to the alveoli which are participating in the gas exchange. So this comprises the first mechanism of flushing of the nasopharyngeal dead space and replacing it with oxygen replete gas, which contributes to one of the major mechanisms of action of efficacy of HFNC. The second important mechanism is the provision of a high flow of inspiratory gases, which minimizes the inspiratory resistance by stenting the nasopharyngeal airway, and also by providing a rapid influx of inspired gas flow, which match or may even exceed the patient's peak inspiratory flow. HFNC helps in reducing the inspiratory work of breathing. The third and one of the most other important mechanisms of HFNC is that by virtue of providing heated and humidified gases, HFNC improves lung mechanics, which means improves the compliance, improves the resistance, and thereby enables better gas exchange. And it also reduces or eliminates the metabolic cost of gas conditioning. So this essentially means that if one were to provide cold medical gases to the neonate, which is typically available at, say, a temperature of 15 degrees Celsius, the gas that is available from our gas ports is cold and dry. it only has, say, less than 0.3 milligrams per liter of water vapor content per every liter of gas. So providing this cold and dry gas is going to significantly increase the work required for the metabolic conditioning of the gases by the inhaled, the pathway, the nasopharyngeal and the tracheal mucosa of the neonate. Not only is significant energy expended in heating this gas, but there is also a lot of energy expended in converting water to water vapor, which is to be added for humidification of this inhaled gas. Instead, when we are to deliver gases at the body temperature, at say 36 to 37 degrees Celsius at 100% relative humidity, which generally translates into something like 44 milligrams per liter of inhaled gas, this significantly reduces the energy that the neonate spends in the metabolic conditioning of the inhaled gases. And additionally, it also improves the pulmonary mechanics, such as decreasing the resistance and improving the complaints. We all are aware that under humidification is very, very detrimental when it comes to respiratory support, especially of preterm neonates, where the mechanisms for vomidification of gas are already compromised. So under humidification can result in impaired surfactant activity, decrease in the functional residual capacity of the lung. It may lead to atelectasis due to drying, and it also compromises pulmonary mechanics and decrease mucociliary action, which in turn requires moisture for its effective action. So the importance of humidification. Okay. So can I move on with the presentation? I hope.
Ma'am, we lost your screen.
Yes, 1 second.
It says low bandwidth.
Okay. So I hope that you are once again able to see my slides, which you should shortly.
You're able to see, ma'am. You're able to see.
So just to illustrate the importance of humidification of gas flow in neonates, let me just quote this crossover randomized control trial, a small trial comprising of 30 neonates. This was basically a crossover type of randomized trial where you know that neonates are crisscrossed, participants crisscrossed from one group to the other group, and the order of exchange of the intervention is what differs between the first and the second group. So in this particular study, in group 1, neonates were treated initially with high flow humidified nasal cannula, followed by the unhumidified non-heated nasal cannula. And in group 2, it was the reverse. The order of exchange of interventions was just the reverse. And what they did find was that in the neonates who were managed with HFNC, which was provided in this study using the device called Vapotherm, if you can look into the second and the third columns, the average score for severity of nasal injury, which was marked by the nasal examination score B, was significantly higher in the group of babies who were treated with non-humidified high flow. So high flow in this study refers actually to the non-humidified, non-heated high flow, whereas Vapotherm refers to the heated humidified nasal cannula group. So we can see that the nasal examination score for injury was significantly higher in the group of babies who were treated with non-humidified, non-heated gases. The average score being 7.8 versus 2.7 in the heated humidified nasal cannula arm. Similarly, respiratory distress, which was scored using a separate system, was also found to be significantly higher in the group of neonates who were treated with high flow nasal cannula as compared to the neonates who were treated with heated humidified high flow nasal cannula, with mean scores being 2 and 1.2. So what it essentially tells us is that the use of heated and humidified gases to support the respiratory status of neonates is associated with lesser incidence of nasal injury and can be associated with significantly reduced respiratory distress scoring. Now, the last mechanism of high flow nasal cannula is to do with the generation of positive end expiratory pressure And this is a sort of dubious mechanism because it is pretty controversial, and various studies have found that the delivered pressures can be very inconsistent and variable. So before going on to this, I'll request Dr. Abhishek to open the second poll. So we are just going to have another question on the generation of PEEP with HFNC. So in a while, you will be able to see the question. And may I request all of you to kindly take the poll so that we keep ourselves interested and engaged in this discussion. So I think you would be able to see the questions now. Which is false regarding generation of PEEP in HFNC? A. Delivered PEEP increases with greater prongs to nares ratio. B. PEEP generated is variable and inconsistent. C. PEEP increases with increase in birth weight at fixed flow rates. So which means if you were to give the same flow rate to a neonate of greater weight, it would generate greater PEEP. And option D, PEEP increases roughly by 0.6 centimeters of water for every 1 liter per minute increase in flow. So I request you all to take the poll now, and we will try and close in 20 seconds. So I hope everyone's taking up the poll. Which is false regarding generation of PEEP, and the options are in front of you. We have another 10 seconds left. Okay. Are we good to go? Okay. So I can see that again, the majority have actually not taken the poll, which is 43%. But amongst those of you who have taken the poll, the most popular option is option C. PEEP increases with increase in birth weight, which is false about PEEP generation HFNC. So that's absolutely right. So the converse is true. PEEP actually decreases with increasing birth weight if you keep the same flow rate. Okay, so we'll go back to the slides. Okay, so there we go. Are we able to see the slides?
Yes, yes.
Yeah, okay. So as we discussed, the generation of distending pressure or positive end expiratory pressure with HFNC is more inconsistent and variable as when compared to CPAP. Now, we are all aware of the Poiseuille's equation, which relates the pressure generated to the flow as well as the resistance of the conducting airway. So we know that for every unit increase in flow, there is actually a direct on pressure, provided the resistance is constant. So you can see this figure here, and on the x-axis is the pressure gradient, and on the y-axis is flow. So with increase in flow, generally the delivered pressure tends to increase, and the vice versa. So whenever there is an increase in the pressure gradient across, say, two ends of a pipe, there would be flow of gas from one end to other, and greater the pressure gradient, greater would be the flow. And similarly, greater would be the flow, greater would be the pressure generated. Now, this obviously depends upon the resistance of the conducting pipe or tube, and higher the resistance, lesser would be the pressure generated for the same increase in flow. And this is absolutely true even with high flow nasal cannula. So when the advent of, even before the advent of HFNC, there were a few bench studies, observational studies, which I have tried and summarized here, which tried to look at the delivered PEEP across different flow rates with different sizes or different diameters of nasal prongs. So the first study by Locke et al. Included around 13 units, a very small observational study, and they used unheated, unhumidified gases at lower flow rates at 0.5 to 2 liters per minute. And they found that with the use of the larger prong, the delivered pressure tended to increase with increasing flow. Although the delivered pressure went as high as 9.8 centimeters of water, and hence it cautioned that unlike CPAP, where we have some idea about the delivered pressure because we also set pressure, in HFNC, we may actually be encountering not only variable and low pressure, but also sometimes higher delivered pressure. The second observational study in 2001 also looked at the delivery of PEEP with different flow rates in unheated humidified use of nasal cannula, and they tried to predict the flow that would be required using a formula to kind of generate a PEEP of 6 if we know the birth weight of the neonate. So the flow rate to generate a PEEP of 6 would be 0.92 plus 0.68 into the infant's weight. So after these initial bench studies, there were a number of clinical studies which also tried to evaluate the delivered pressure with HFNC. And a summary of these studies has been that the measured high flow pressures or the measured pressures in the pharynx were similar to or lesser than those which were set with CPAP. PEEP did increase with increase in flow, and we will be looking into this a little bit more in detail in the next slide. High flow pressures tended to increase with decreasing infant weight. So smaller the baby, more was the PEEP delivered with the same flow rate. And the PEEP delivered tended to vary between patients and also between the type of interface used, and particularly with regards to the prongs to nose diameter. So what do we mean by prongs to nose diameter? It is nothing but the ratio of the outer diameter of the prongs used, like you can see here, divided by the internal diameter of the nostril. So greater the prong to nares ratio, greater would be the delivered PEEP. So taking the first consideration here, what is the relation between flow and the PEEP delivered? So in this study, which included 44 preterm neonates, again a crossover RCT of HFNC followed by CPAP or CPAP followed by HFNC. The investigators try to look at various physiological variables, including the compliance, the delivered PEEP, etc., with the use of HFNC and CPAP. And what they found was that with increasing flow, you can see here in the first row that HFNC flows are increasing from 2 to 8 liters per minute. The delivered PEEP in centimeters of water also tended to increase from as low as 2.3 centimeters pressure at a flow rate of 2 to as high as 6.1 centimeters at a flow rate of 8. The PEEP was always greater with the mouth closed when compared to the mouth open. And you can see that the p-value comparing the delivered PEEP with mouth closed versus mouth open across different flows was always statistically significant. So a higher PEEP was always delivered when there was lesser leak, particularly when the mouth was closed, and this difference also varied based on the set flow. Now what they also found was PEEP delivered increased by 0.6 centimeters of water with every 1 liter per minute increase in flow, and this increase ranged from 0.42 to 0.61 centimeters of water. When the same concept was plotted as a scatter plot, which you can appreciate now on the figure to your right side. So there was a positive correlation between the flow in liters per minute per kg. This is flow per weight, per kilogram weight of the neonate versus the PEEP in the y-axis. However, the variation of delivered PEEP became more diverse at flow rates crossing 6 liters per minute. So you can see that to the right half of the figure, the variability in delivered PEEP becomes more diverse. So which means that at higher flow rates, more than 6 liters per minute per kg body weight, the delivered PEEP can be very variable. So on an average, it is true that the PEEP tends to increase with increasing flow, and this is more true when the mouth is closed. Now coming to the concept of the prongs to nares diameter, this study again illustrated the delivered PEEPs at different flow rates, and this particularly looked at different types of HFNC interfaces. So each line here represents a different prong size, or rather a different ratio of prongs to nares. And we can see that the top 4 lines, which represent the highest PEEP generated, were all associated with a prongs to nare ratio of more than 0.6. Or rather, you can say if the ratio was anything below 50% or 0.50, even at flow rates of 5 or 6 liters per minute, you can see that the delivered PEEP was pretty low. So in the top 4 lines here, where the delivered PEEP tended to be higher, the prongs to nares ratio was inevitably more than 0.5. So this brings the next important kind of message, that the delivered PEEP varies strongly with the prongs to nares ratio, and it is only when it is above 60% and at flow rates above 5 to 6 liters per minute that we get to see a substantial delivery of PEEP. Delivered PEEP is also a function of the birth weight of the neonate, and as we have already discussed, the flow rates, even when kept fixed flow rates, the same flow would be generating lesser PEEP for a baby with a higher birth weight, as we can see in this figure. Say, for instance, if you were to use flow rate of 4 liter per minute, it generates a pressure of around 2.5 to 3 centimeters in a neonate of 2000 grams birth weight, when compared to a pressure of maybe 4 to 5 centimeters when used for a neonate of 500 grams birth weight. So smaller the baby, greater is the PEEP delivered for the same flow rate. And this figure essentially summarizes the findings of few studies which have tried to look at the effect of different varying flow rates on the PEEP, and barring the 2 studies indicated by the black and the green line, Collins and Wilkinson et al., most of the other studies showed inconsistent or variable effect of increasing flow on the delivered PEEP, and you can see the lower 3 lines almost showing a static or even a declining trend of PEEP with increasing flow. So what we do see is there are multiple factors which seem to determine the delivered PEEP with HFNC. We do know that the more is the prongs to nares ratio. The higher the prongs to nares ratio, the higher is the delivered pressure. The same flow generates higher pressure when the mouth is closed when compared to when the mouth is open. Higher the flow in relation to the inspiratory demand of the patient. So the smaller the patient, higher will be the pressure delivered for the same flow, whereas the larger the patient, lesser will be the PEEP generated. And at leaks of more than 50%, the delivered pressure is almost negligible. But in order to achieve the first mechanism of action, which is flushing of the nasopharyngeal dead space, some degree of leak is actually preferable. So this is the next concept of the variability of oxygen concentration delivered with HFNC. So we probably have a poll here also. Can we take a poll 3, please, Dr. Abhishek?
Sure, ma'am.
So the next concept will be about the delivery of FiO2 in HFNC. So I hope you can see the questions now. The following is true regarding FiO2 delivery with HFNC. A, HFNC ensures that set FiO2 is delivered to the neonate exactly. B, FiO2 delivery is within 5 to 10% of the set value. 3, or option C, FiO2 delivery is more reliable if the flow rates are less than 3 liters per minute. D, FiO2 delivery is more reliable in neonates with larger tidal volumes. So please go ahead and kindly choose whichever is the option that you feel is true with regards to the delivered FiO2 concentration with HFNC. Okay, so I think we have 10 more minutes to go. I hope you are all participating in the poll and not getting bored. I think we must be ready to summarize the results. Okay, so one good thing is a lesser proportion of participants have now not opted to answer, so which is encouraging. So most of you have chosen B as the correct option, and that's again Absolutely right. So you're all right in choosing option B. Yes, the delivered FiO2 is within 5 to 10% of the set FiO2. That is precisely right. So obviously option A is wrong. HFNC cannot guarantee accurate delivery of the set FiO2. The FiO2 delivery is more reliable at higher flow rates, as we will be seeing in the coming 2 to 3 slides, and it is also more reliable in smaller neonates with lesser tidal volumes. Hence, options C and D are also wrong. So with that, I think we'll go back to the slide sharing. So let me share my screen again. So are you able to see the screen?
Yes, ma'am.
Okay. So as we discussed, FiO2 delivery with HFNC may not be 100% precise and accurate. So let's look at this study. What did it find? So the study essentially tried to look at the delivered FiO2 concentrations at different flow rates. So the bar, which is black in color, represents 3 liters per minute. Red one represents 5 liters, and the green bar represents 7 liters per minute. And this is in a group of infants with various tidal volumes. So starting from 20, then 30 and 40 ml tidal volume. So obviously the group of bars on your right side represents the delivered FiO2 in larger neonates. And what did they find? So when they were at a set FiO2 of 30%, fairly you can see that with all bars, the FiO2 which is delivered is also nearly around 30%, although with the red and the green bars, this is actually precisely dot on 30%. So these represent the higher flow rates at 5 and 7 liter per minute. So using a flow rate of 3 liter per minute may not achieve the desired FiO2 even at 30%. The difference becomes a little bit more marked when we set an FiO2 of 50% or 0.5. And you can see that now almost in all the 3 groups of babies, both the smaller, the medium-sized and the larger neonates, as shown by the tidal volumes, both the black bars and the red bars are falling short of the FiO2 of 50%, which means even at 3 or 5 liters per minute, we are unable to sort of deliver the FiO2 which is desired. And when we set FiO2 of 70%, it becomes even more difficult to reach the set FiO2, even in the smaller neonates with tidal volumes of 20 ml, both with 3 and 5 liters per minute. Although the flow rate of 7 liter per minute manages to just deliver the FiO2 in this group, even that flow does not guarantee the delivery of 70% FiO2, especially in the larger neonates. So what we understand from this is that if we are using flow rates higher than 3 liters per minute, we are more likely to deliver the FiO2 closer to the set FiO2. And lower the flow rate, that is lesser than 3 liters per minute, and larger the baby, bigger the baby, which means if the tidal volumes of the baby are greater than 30 ml, then we may end up delivering an FiO2 which is lesser than what we have set. And this difference may be anything between 5 to 10%. So with this discussion, I will move on to the next section of the talk, which will be on different devices and interfaces. And I see a poll coming up here. So can we take up this poll too, poll 4? So in a moment, you will be able to see poll 4. So from henceforth, we have less of physiology and we'll have more of practical aspects. So we will be discussing devices and then followed by evidence and clinical recommendations. Okay, so here we go. Which of the following is not a part of HFNC system? A, underwater seal, B, blender, C, servo control heater humidifier system, and D is interface. I think this one must be very easy. Which is not a part of HFNC system, not a part of the anatomy of HFNC. So probably we'll just finish in 5 seconds because it's a very short question. Yes, so shall we see the results? Great, so a whopping majority has voted for the right option, which is option A. which is underwater seal. So obviously underwater seal is not a part of HFNC. It is only a part of bubble CPAP circuits. And this is one of the marked aspects of difference between HFNC and CPAP systems. So the anatomy of any HFNC system comprises of a blender which serves to blend air and oxygen, the inspiratory circuit which takes these gases, the blended gases, to the servo control heated humidifier, where they get heated to 37 degrees and to 100% relative humidity, and they are carried to the patient using the inspiratory circuit. I think you have lost screen sharing once again. Let me try to redo it. Okay, so there we go. So which is delivered, the heated and humidified gases are delivered through the inspiratory circuit to the neonate using an interface. So this is the typical anatomy of HFNC devices, and we have different types of HFNC devices. The one on the left part of your screen is the OptiFlow system available from Fisher & Paykel. You can also see the Vapotherm Precision Care, which is not so commonly available in our country. Probably it is recently been made available. And the third one, which is a US-based system, is the Comfort Flow by Telflex company. This, in addition to the Airvo system, which is also available from Fisher & Paykel, are the HFNC devices that we currently have in our country. So Airvo 2, as you can see here, is again a HFNC system that can be used across neonatal, pediatric, and even adult HFNC usage, with a wide range of flow rates from 2 to 60 liters per minute, and with FiO2 range from 21 to 100%. And the temperature of the gases can also be adjusted between 31 to 37 degrees Celsius. Now, HFNC systems are available with a variety of HFNC interfaces as well. And as we can see here, the OptiFlow and Airvo are to be used with the Fisher & Paykel HFNC interfaces, which have also evolved from generation to generation. So the first generation HFNC cannula looked pretty much like the routine nasal cannula. And then came the OptiFlow Junior interfaces, which were specialized neonatal HFNC interfaces. And they have further got it revised now with OptiFlow Junior 2, which you can see here on this slide, which is now available in 5 different sizes, starting from extra small, small, medium, large, and extra large. And each of these interfaces comes in its pamphlet with the range of birth weights, the range of gestational ages, and the range of flow rates across which it can be used. And the current generation OptiFlow Junior 2 interfaces come with some specialized features, including the flexible shape, the bend here that you can see, which is kind of made to accommodate any movement of the neonate's cheek, so that the HFNC interface does not slip out. It is also made in a way to cater to a wide range of flow rates, starting from 0.5 to 25 liters per minute. It utilizes the same wiggle pad variety way of fixation as in other HFNC OptiFlow interfaces, and has the so-called breathable tubings, which allow the water, if any condensate present, the water may easily be penetrable through these tubings, and hence it does not interfere or does not increase the resistance of the tubings. Now, we have discussed about the available devices, and we shall be moving into the evidence comparing HFNC and other modes of non-invasive respiratory support in neonates. And before we begin this, we have one more poll for you, Dr. Abhishek. We'll move on to poll 5 now. So this is the last poll. So evidence on HFNC versus CPAP, although evidence may be full of numbers, is probably very, very important, because it has some important messages which have clinical implications. So here we go. What is the current status of evidence from studies on the role of HFNC versus CPAP? A, HFNC has been shown to be superior to CPAP in RDS. HFNC is non-inferior to CPAP in post-extubation setting. HFNC may be associated with greater risk of air leaks and nasal trauma than CPAP. D, HFNC has been shown to reduce total duration of respiratory support. So which of the following would you think is correct? So our audience has been extremely correct in all their responses so far. Probably they did not need the talk on HFNC. So let's see what is the result of the last poll. Are we ready? Okay, here we go. So yet again, you're all absolutely right, with more than 50% choosing option B. So yes, HFNC has been shown to be non-inferior to CPAP, or can be used as an adjuvant to CPAP only in the post-extubation setting. And I'll be talking to you about how HFNC has been clearly shown to be inferior to CPAP in primary RDS setting. So option A is wrong. HFNC is actually associated with lesser air leak and lesser nasal trauma than CPAP, and it may sometimes be associated with increased duration of respiratory support. Hence, option B is the most correct answer. So let's go back to evidence, and so this is although studies full of studies, I'm sure it would be interesting. So we'll discuss evidence or studies comparing HFNC versus CPAP in the following settings: respiratory distress syndrome, post-extubation support, or what we call as secondary respiratory support, and in the context of apneas. So HFNC in RDS is clearly out now. Why? And this is what evidence says. So there are multiple systematic reviews now comparing HFNC versus CPAP in the primary support of neonates with respiratory distress syndrome. So we are talking about preterm neonates with surfactant deficiency, likely hyaline membrane disease, with respiratory distress onset less than few hours of postnatal age. And in this group, now we have at least 3 non-inferiority trials which have shown that there is a higher incidence of treatment failure with HFNC when compared to CPAP. So the net effect is 18% treatment failure with HFNC versus 10% with CPAP. So you can see that the relative risk of treatment failure is 93% greater. Our relative risk of 1.93, which is statistically significant because both ends of the 95% confidence interval lie on the higher side of 1. So definitely associated with more treatment failure. And how much more is this? It is 82 per 1,000 neonates have a higher risk of treatment failure when supported with HFNC when compared to being supported with CPAP. However, this did not translate into any difference in the need for mechanical ventilation or bronchopulmonary dysplasia, probably because the neonates who had treatment failure with HFNC were subsequently rescued with CPAP. So they didn't really require intubation ventilation, and they fortunately were not at higher risk of bronchopulmonary dysplasia. Yes, the use of HFNC was associated with a lower incidence of nasal trauma, from 9% with CPAP to 5% with HFNC. So almost 49% lesser risk of nasal injury with the use of HFNC. You can find this evidence beautifully summarized in the recently published NNF Clinical Practice Guidelines 2020, which was published in Neocon Hyderabad, and which is available in the NNF website, freely downloadable. So as we have just discussed, you can find that the rate of failure of primary respiratory support was significantly higher with a group of neonates treated with heated humidified nasal cannula. 195 neonates per 1,000 tended to have HFNC failure when compared to 101 per 1,000 neonates who tended to have CPAP failure when these were used as a primary mode of support. And this is reasonably robust quality of evidence, moderate quality of evidence coming from 8 randomized controlled trials involving 2,000 plus neonates. No difference in the need for intubation. I would just like to go through 2 landmark randomized controlled trials in a little bit more detail. Probably I'll take 1 minute each. So one of them is the HIPSTER trial, which was published by Roberts and group in NEJM 2016. They included 564 preterm neonates less than 72 hours of age. And these were neonates who were more than 28 weeks of gestation age. So they did not even include extremely preterm neonates who may actually be at a higher risk of treatment failure. So this was actually in relatively mature neonates, neonates with gestational age more than 28 weeks of gestational age. The intervention comprised HFNC provided with either OptiFlow or vapotherm with flow rates of 6 to 8 liters per minute, and control group was supported with bubble CPAP with PEEP of 6 to 8 centimeters of water. Criteria for treatment failure were defined as FiO2 requirement more than 40% with the presence of respiratory acidosis or apneas. And what they found was that treatment failure was higher in the HFNC group, and it was 26% in HFNC versus almost one half, 13% in the CPAP group. And they actually stopped the randomized control trial midway because an interim analysis showed a stark difference in the incidence of treatment failure being much greater with HFNC. Hence, it was ethically no longer valid to continue with the randomized control trial. Now, if we dig a little deeper into HIPSTER trials, we will find that the population of neonates were actually at low risk for failure of non-invasive ventilation. And why do we say this? Because they were mature neonates, mean gestational age of 32 weeks, reasonably good birth weight, 1,737 to 1,750 grams. 80% had complete coverage with antenatal steroids, and oxygen requirement at enrollment was just 21%. So these neonates had absolutely no reason to have non-invasive ventilation failure, and it is surprising that 26% of them developed treatment failure with HFNC. There was no difference in intubation rates in the HIPSTER trial as well, because CPAP could be successfully used to rescue the neonates who failed with HFNC. However, the median duration of respiratory support was 1 day longer with HFNC, and this trial also echoed the lower risk of nasal injury with the use of HFNC. So the higher rate of treatment failure among neonates may probably reflect the reduced effectiveness of HFNC in surfactant deficient lungs, was what the authors discussed in the discussion of the HIPSTER trial. And they also acknowledged that although they chose to exclude the neonates who were less than 28 weeks, who may deem to have a higher risk of non-invasive ventilation failure, they still found that the risk of treatment failure was much more with HFNC. Similar findings were also found in an Indian trial, and this was spearheaded by Dr. Murki sir from Fernandez Hospital, Hyderabad, and Dr. Nandkishore Kabra sir from Surya Hospital, Mumbai. This was a multi-center randomized control trial published in Neonatology 2020. And they also found that they had to stop the trial midway because of a higher incidence of treatment failure in the HFNC group, 26.3% versus just 7.9% in the CPAP group. The Indian trial had some differences from the HIPSTER trial in the sense that they allowed flow rates to be increased only until 7 liters per minute. They also used OptiFlow or Airvo. They did not use vapotherm. And unlike HIPSTER, which increased flows until 8 liters per minute, they only increased flows until maximum of 7. And so also with CPAP, they only used a maximum CPAP of 7 centimeters of water. The criteria for treatment failure were slightly different in the sense that FiO2 requirement more than 60% was taken as one of the criteria, along with the presence of respiratory acidosis, pH below 7.2, CO2 more than 60 with recurrent apneas, and increased Silverman-Anderson score more than 2 was also taken as a criteria for failure of primary mode of support, unlike the HIPSTER trial, which did not take any of the clinical parameters for respiratory distress. Again, because of the high incidence of treatment failure, this trial also had to be stopped short with an inclusion of just 272 neonates out of the pre-calculated sample size of 436. The Indian trial RCT not only found that neonates managed with HFNC had a higher incidence of treatment failure, but also they developed treatment failure earlier when compared to CPAP. So this is a Kaplan-Meier graph which shows the blue line representing the neonates managed with HFNC had treatment failure at a mean age of just 3 hours, which you can see here, when compared to the group of neonates who were managed with CPAP, where the mean age to CPAP failure was 22 hours. So it seemed that HFNC resulted in much earlier and much greater treatment failure. This was a non-inferiority trial, as we already discussed. And despite choosing a non-inferiority margin of up to 5%, which meant that the investigators were ready to accept a treatment failure rate greater by up to 5% in HFNC because of better safety profile, better ease of administration. They found that the treatment failure was actually greater by 18.4%, and even the lower limit of the 95% CI was much more than 5%. It was 9.7%. More treatment failures were noted in the group of neonates with more severe respiratory distress, with a Silverman score more than 5, and in the more preterm neonates less than 32 weeks of gestational age. Some notable differences in the population again were that the neonates in the Indian trial were enrolled earlier at 0.5 hours. They had an average higher FiO2 requirement at the time of enrollment, ranging 0.4 to 0.5 versus just room air in the HIPSTER trial. So these neonates tended to be more sicker. Of course, the maximum flow rate we have already discussed, and they used a more liberal FiO2 cutoff for defining treatment failure. So for some of us, these terms may be different. So I've just made one slide to just show what the concept of non-inferiority means. Now we know that there is this line, the red line in the center, which represents the line of no difference between the test treatment and the standard treatment. So typically in the superiority RCT, we work on the hypothesis that we may find that a test treatment may be different from the standard treatment. And if we find that the relative risk of the risk difference of the outcome of interest and the 95% confidence intervals lying entirely to the right of this line of equivalence, then we conclude that the test treatment is better than the standard treatment. Now, in a non-inferiority trial, we pre-decide a margin of inferiority, say 5% or 10% inferior outcome when compared to the standard outcome may be acceptable to you as a clinician because the test treatment may offer some other advantage like better safety profile. So in this, the last study that we discussed, 5% higher risk of treatment failure was taken as acceptable by the authors or the investigators of the study. If they had found that the relative risk or the risk difference and the 95% confidence intervals lying anything like this, the second, third, or the fourth line, wherein at least the lower limit of the confidence interval had not crossed the non-inferiority margin, they would have still concluded that HFNC was non-inferior to CPAP. However, they found the relative risk and the 95% CI to lie entirely to the left of the non-inferiority margin, and hence they had to conclude that HFNC was clearly inferior to CPAP in the primary treatment of respiratory distress syndrome. Now, in terms of cost effectiveness, we have two types of cost here, initial cost and the cost of consumables. And this analysis from the NHS network of UK showed that although there was initial cost of initiation was higher with CPAP, the running cost with consumables was actually slightly lesser with CPAP. However, in Indian scenario, this may not be true because we have a lot of low-cost CPAP devices, standalone CPAP devices, including the underwater bubble CPAP, which are available at a very competitive cost. And the running cost in terms of consumables in our own unit when we worked out was not very different between HFNC and CPAP. However, because of the additional duration or prolongation of respiratory support, we may actually end up increasing the cost of care while using HFNC when compared to CPAP. So to summarize evidence in primary supportive distress, HFNC is not recommended for the management of preterm neonates with respiratory distress syndrome or with surfactant deficient lungs, and this is a strong recommendation made by the NNF CPG 2020 based on moderate quality of evidence against HFNC, showing higher risk of treatment failure and also lack of benefit in reducing ventilation, mortality, and BPD. HFNC has been shown to reduce the rate of nasal trauma, and it may be considered as an alternative to CPAP in infants with high risk of injury. Dr. Abhishek, do I have maybe another 5 minutes to wrap up?
Sure, ma'am, you can take.
Okay. So moving on, HFNC in the post-extubation setting. So how does it fare? So when we look at the evidence, So this is again the meta-analysis of around 10 randomized trials comparing HFNC versus CPAP in the post-extubation setting. There is absolutely no difference in the incidence of death, bronchopulmonary dysplasia, and their combined outcome. May I request the other participants to please remain muted? Okay. HFNC is, however, associated with lower risk of air leaks and nasal trauma in this subset. And this was again summarized in the NNF guidelines, the clinical practice guidelines published in the year 2020 again. So we can find here that HFNC use did not translate into any difference or benefit in terms of hard outcomes like mortality or bronchopulmonary dysplasia. Yes, there was reduction in the risk of developing air leaks by nearly 71%. You can see the relative risk of 0.29 and the confidence intervals lie to the left of 1. So it shows that there is significant reduction. This is the forest plot from the Cochrane review in the post-extubation setting. Again, showing that overall, when we compare HFNC versus CPAP for post-extubation, there is no difference in the risk of re-intubation within 7 days of extubation. So you can see that the pooled relative risk is 0.91 with 95% confidence intervals 0.68 to 1.2. So there is absolutely no difference. There is also no difference in the subgroup of infants less than 28 weeks or more than 32 weeks. But interestingly, in the group between 28 to 32 weeks, there seemed to be a lower risk of need for reintubation with the use of HFNC. However, one has to accept that there may be an associated increase in the duration of respiratory support with the use of HFNC, as has been seen in all these randomized trials, where the total duration of respiratory support became longer with the use of HFNC. So 4 days versus 2 days in Yoder study, and 18 versus 10.5 days in the Hattie's study. So the prolonged duration of respiratory support may be a hindrance to families and also for the costing. So to summarize evidence in the post-extubation setting, here HFNC does seem to be a reasonable alternative to CPAP because there is no difference in terms of efficacy, although there is also no benefit in terms of reduction in mortality or BPD. There is some difference or benefit in terms of reduction of air leaks as well as nasal injury. Although healthcare providers are unlikely to give very high value to the beneficial effects on air leak because it's a very subjective outcome, and most of these trials, we must remember, are non-blinded trials. There is uncertainty regarding the delivered pressure and widespread use in availability in many settings in India. So in the opinion of the CPG guideline writing committee, they still recommend that it may be preferable to extubate preterm VLBW neonates to CPAP because of the lack of benefits in any of the hard outcomes with HFNC, such as mortality or BPD. There is a role of HFNC in the management of apnea of prematurity, and there was a small trial published in this context. A word on HFNC versus standard oxygen in pediatric management of bronchiolitis. So this was another recently published systematic review, and it included 4 trials which compared standard oxygen versus humidified heated high flow nasal cannula in management of bronchiolitis in infants. And you can see across these 4 RCTs, we don't have a pooled RR here, but you can see 12% versus 23%, 14 versus 33%. So treatment failure was lowered with the use of HFNC as compared to standard oxygen therapy, even in the management of bronchiolitis in infants and children. However, there was again no difference in intubation or the need for PICU transfer. So HFNC is used as a rescue mode when there is treatment failure with standard oxygen therapy. So I'll quickly run through the practice points because we are running short of time. So when it comes to the clinical guidelines on the usage, there are various bodies which have come up. There are various review articles which have come up with guidelines on the use of HFNC in preterm neonates. So there are flow rates which are recommended for initiation of HFNC, which are based on the baby's birth weight, and they range anything between 4 to 6 or 3 to 5 liters per minute. Typically begin with a higher flow rate, say 5 liters per minute in a term neonate or a neonate more than 3,000 grams. And begin with an FiO2 of 30 to 40%, but rapidly adjust FiO2 based on the saturations, and a blender is obviously a must when we use HFNC. Now, escalation of flow can be done in steps of 1 liter per minute if the neonate has signs of increased work of breathing, and if the neonate has persistently an FiO2 requirement crossing 40 to 50% with the presence of respiratory acidosis with or without recurrent episodes of apnea, then the neonate is deemed to have had HFNC failure and must be rescued with CPAP or higher modes of say NIV or invasive ventilation. Weaning can be initiated when the neonate is stable for at least 12 to 24 hours. And remember to please wean FiO2 initially in decrements to bring it down to 21%, followed by flow rates at again the rate of 1 liter per minute every 12 to 24 hours of stability. The same has been kind of recapitulated in this table. So we need to remember that there are some neonates who are at higher risk of HFNC failure, including the ones with higher FiO2 requirement right from the initiation, and post HFNC, those who continue to have acidosis, low pH, elevated carbon dioxide, and with radiologically and clinically diagnosed respiratory distress syndrome. So these neonates are at higher risk of failure when compared to neonates with conditions like TTNP. So to summarize, CPAP, although may be hurtful to the nose of the neonate, so I've kind of tried to compare it with a bitter gourd, which may be not good to taste, but is more effective for the body. So is more efficacious as a mode of respiratory support to neonates. And in contrast, HFNC may be compared with a gulab jamun. It may be attractive, it may be easier for the neonate, easier for the families, and simpler for the nurses. But when it comes to clinical efficacy, one has to look at it, take it with a pinch of salt and with caution, because it may be associated with decreased efficacy, particularly in neonates less than 28 weeks, where evidence for its use is still not available in a large way. So I leave this last slide for your reflection, and since we have run out of time, I'll be happy to take any questions before we wind up the session. Over to you, Dr. Abhishek and Dr. Pradeep.
Yeah, thank you.